Welcome back to the deep dive. Today, we are not just navigating through theory. We are executing a mission that's absolutely critical to your professional life and, more importantly, to future patient safety. For those of you preparing for your MD anesthesiology exams, you already know this topic isn't just high yield. It's really the cornerstone of emergency airway management.
It truly is.
We're undertaking a comprehensive, exam-focused deep dive into rapid sequence induction, or RSI. We are essentially going to build the perfect 20-mark answer together.
That's exactly the right way to frame it. RSI is a staple query in the DNB and Gujarat University examinations.
Right.
It appears constantly, as a major long answer or very focused Viva station.
Right.
So our goal today is to dissect this topic meticulously. We want to make sure you master the indications, the preparation, that checklist that saves lives, the technique, and of course, the critical pitfalls.
And we'll structure this discussion exactly as you should be structuring your notes for maximum recall. Okay, so let's unpack this, starting with the fundamental academic definitions. When an examiner asks, what is RSI? We need a definition that captures both the objective and the procedure with, high-scoring terminology.
Right. For that academically rigorous definition, you want to say that RSI describes a time-critical sequence of interventions during the induction of general anesthesia.
Time-critical, I like that.
And it has two essential simultaneous goals. Firstly, and this is the big one, minimizing the risk of pulmonary aspiration of regurgitated gastric contents.
Okay, so preventing aspiration.
And secondly, minimizing the overall time interval between the patient losing consciousness and securing the airway with a cuffed endotracheal tube.
So if that's the conceptual goal, what is the precise procedural difference? What really sets RSI apart from a standard induction of anesthesia?
Well, the procedural definition is non-negotiable, and it really hinges on speed. It's the virtually simultaneous administration of a potent, rapid-onset, sedative hypnotic agent, immediately followed by a rapid-onset neuromuscular blocking agent, an NMBA. This combination achieves rapid unconsciousness and the muscle relaxation you need for emergency tracheal intubation. And you're aiming for cuff inflation, airway security, within a window of about 60 to 90 seconds.
And classically, this whole process relies on cricoid pressure, doesn't it? The Sellick maneuver.
It does. It classically relies on the immediate application of firm cricoid pressure to provide that physical protection during the vulnerable period.
So the primary purpose is crystal clear. Rapidly securing the airway with a cuffed ETT to minimize pulmonary aspiration risk. But why does this specific procedure earn that dual title of being high yield for the exam and high risk in practice?
Well, it's high risk because pulmonary aspiration of gastric contents is a rare but absolutely catastrophic complication. It can carry a mortality rate that exceeds 50%.
50%.
Yeah. So RSI is a standardized technique designed specifically for patients where this risk is imminent. The speed and the rigidity of the steps are crucial. Any deviation or delay directly increases patient morbidity and potentially mortality.
And that's why it's high yield for the exam.
Exactly. It's high yield because of this inherent risk and criticality. Examiners use RSI to test not just your book knowledge of pharmacology, but your ability to perform under pressure, your knowledge of crucial contraindications, and your mastery of that pre-induction checklist.
Could you just quickly summarize the common ways the university examination specifically asks about RSI? I think this helps the student organize the material we're about to cover.
Certainly. You should be prepared for three primary formats. 1, a 20-mark long answer. This will require a detailed, stepwise description of the technique, a discussion of its modifications like modified RSI, and a detailed breakdown of pitfalls and complications.
Okay, the full deep dive.
The full thing, too. Short notes. These will focus on specific elements like the contraindications of Succinylcholine or the controversies around cricoid pressure or maybe the role of Rocuronium and Succinylcholine.
More targeted questions.
Exactly. And 3, scenario-based Viva questions. For example, they might say, you have a 32-year-old female, 36 weeks pregnant, requiring an emergency laparotomy for appendicitis. Detail your induction plan, your drug choice, and your positioning.
Got it. And our deep dive today will cover all of those facets.
It will. We'll give you the detailed content needed for all those comprehensive answers.
Excellent. Before we tackle the preparation checklist, we really need to understand the catastrophic mechanism we're fighting against. What is the physiological ticking clock driving this whole procedure? Let's start with the critical thresholds for gastric aspiration leading to severe pneumonitis or Mendelssohn syndrome.
Understanding these thresholds is vital for the exam. Based on the foundational work on aspiration pneumonitis, the critical threshold for severe chemical pneumonitis involves the aspiration of gastric fluid volume greater than 0.8 millirel/kg of body weight.
Okay, 0.8 milliliter per kilo.
And a pH level less than 2.4.
So it's not one or the other, it's both.
Both criteria must be met to maximize the chemical injury. An aspirate that is highly acidic and voluminous drastically increases the risk. But, the presence of particulate, matter-like, partially digested food just exacerbates the physical blockage and the subsequent inflammatory response.
Yeah.
It makes the injury far more severe and much harder to manage.
And what's the sequence of events in the lung immediately after this acidic, potentially chunky fluid enters?
The injury is swift and frankly devastating. The acid acts as an immediate chemical burn to the bronchial tree and the alveolar tissue.
A chemical burn?
Yes, and this leads rapidly to atelectasis, followed by massive alveolar edema and hemorrhage. Critically, this destroys the surfactant layer, which is what normally maintains alveolar patency.
So the alveoli just collapse.
They collapse. The consequence is a rapid, widespread collapse of lung units, leading to profound interpulmonary shunting. Blood flows past these unventilated alveoli, it fails to pick up oxygen, and this results in life-threatening hypoxemia. It's a process that can escalate to ARDS very, very quickly.
And we also need to remember silent regurgitation, right?
Absolutely. This passive reflex can occur at any time, even with a light plane of anesthesia. It emphasizes that the airway is unprotected from the moment that gag reflex is suppressed until the ETT cuff is inflated and secure.
This brings us to the protective mechanisms that our anesthetic agents just obliterate. The lower esophageal sphincter, or LES complex, is often a detail you need for a long answer. What makes this sphincter complex so resilient in the first place?
The LES is a highly evolved protective apparatus. It's designed to prevent reflux even against significant pressure gradients. It consists of 4 integrated components. First, there's the physiological muscular sphincter itself.
Okay.
Second, you have the plug-like action created by the mucosal folds at the gastroesophageal junction. Third, there's a valve-like effect from the obliquity of the esophageal the ankle of his.
Right.
And finally, the crural diaphragm, or the diaphragmatic sling, which acts as a sort of external pinchcock mechanism, maintaining the normal anatomical position of the cardia.
It sounds incredibly robust. So how precisely do our common induction agents dismantle this highly effective defense system?
Well, almost all of our induction agents, Propofol, thiopentone, even Etomidate, they cause a dose-dependent decrease in LES tone.
So they relax it.
They relax it.
Yeah.
And when you combine that with the complete obliteration of the protective cough and gag reflexes by the anesthesia, the physical barrier against reflux is just dramatically weakened.
And if the patient has high intragastric pressure to begin with.
And passive reflux becomes highly likely. And we should also mention the specific mechanism for succinylcholine. Those initial depolarizations and fasciculations can transiently increase intragastric pressure, potentially overcoming any remaining LES tone. Though, to be fair, the evidence linking those fasciculations directly to increased aspiration is still a bit controversial.
Okay, so the aim of RSI is a race against this physiological collapse of protection.
Yeah.
How exactly does the protocol minimize aspiration risk? What are the 2 main pillars of protection?
RSI minimizes risk through the twin pillars of speed and occlusion. The speed is mandatory. We have to transition from the patient being conscious to having an inflated ETT cuff in the trachea in the minimum time possible. That's the 60 to 90 second rule.
Right, minimizing the exposure time.
Exactly. And the occlusion is achieved via the physical application of cricoid pressure, the Sellick's maneuver, which aims to compress the esophagus against the cervical vertebrae, acting as a temporary external valve.
Right. Let's move on to the indications. This is always a crucial list for the exam. When an examiner asks for the indications for RSI, the first non-negotiable answer has to be a full stomach. So we need to detail the current ASA criteria that define that.
You must state the specific ASA NPO guidelines very clearly. A full stomach is defined by inadequate observance of these fasting guidelines.
So what are they?
For solids and non-clear liquids, including milk and formula, it's less than 6 hours fasting.
6 hours for solids.
For breast milk, it's less than 4 hours. And for clear fluids, we're talking water,
Yeah.
tea without milk, black coffee, clear fruit juices without pulp. It's less than 2 hours fasting.
2 hours for clear fluid. Got it. Now, emergency surgery and trauma patients are a classic cohort requiring RSI. What is the fundamental dogma here, and what are the physiological reasons that back it up?
The dogma is simple, and it is life-saving.
Yeah.
All trauma patients must be presumed to have a full stomach, regardless of their stated NPO time.
Regardless.
The physiological reasons are complex. Trauma victims often swallow large volumes of blood from facial or nasal injuries. Plus, the massive catecholamine release associated with severe physical or psychological stress significantly inhibits gastric motility.
So it slows everything down.
It just delays gastric emptying. And if the patient recently received oral contrast medium for imaging, that also contributes to gastric contents. So the RSI protocol is mandatory unless there is concrete, clinical, and radiological evidence to the contrary, which is, extremely rare.
What about acute abdominal pathologies?
Oh, absolutely. Acute abdominal conditions that impede gastrointestinal flow are clear indications. Intestinal obstruction, for example, whether it's small bowel or large bowel, prevents contents from moving forward,
Which leads to stomach distension.
and reflux risk. Similarly, a strangulated or incarcerated hernia causes obstruction and a rapid pressure buildup. These are non-negotiable RSI indications.
Pregnancy is another classic indication for RSI, particularly from the second trimester. We touched on the mechanism, but let's just reiterate the clinical importance here.
The risk in pregnancy is persistent, and it's multifactorial. Hormonal changes, specifically the high levels of progesterone, cause generalized smooth muscle relaxation. This dramatically decreases LES tone and makes sphincter incompetence a baseline risk.
And then there's the mechanical pressure.
Exactly. As the pregnancy advances, the mechanical effect of the enlarging uterus increases intragastric pressure. So, given this combination of decreased tone and increased pressure, RSI is generally indicated from the second trimester onwards for any procedure, and certainly for all emergency obstetrical procedures like a cesarean section.
Beyond the acute indentations, we must also list the chronic comorbidities that place patients at high risk. This shows real critical depth in an answer.
This is the subtlety the examiner is looking for. You have to list the patients who suffer from chronic conditions that delay transit time.
Sure.
1. Morbid obesity. You have increased intra-abdominal pressure and a baseline decreased FRC, which exacerbate reflux and aspiration risk. 2. Diabetic gastroparesis. This is a manifestation of autonomic neuropathy that essentially paralyzes gastric emptying.
Right.
Then you have pre-existing GERR or a hiatus hernia. These patients have baseline LES dysfunction. Severe pain, anxiety, or high opioid use also independently slow gastric motility.
And what about having a nasogastric tube in place?
That's a great point. The presence of an NGT, while it's often used to decompress the stomach, the tube itself can prevent the complete closure of the LES. It can act as a wick for reflux.
In these high-risk elective or semi-elective situations, we rely heavily on pre-induction prophylaxis. What's the standard pharmaceutical regimen?
The standard regimen aims to do two things: reduce the acidity of the stomach contents and enhance gastric emptying and LES tone.
Okay, so how do we do that?
It involves H2 receptor blockers like ranitidine 30 milligram IV or proton pump inhibitors, PPIs like omeprazole 20 milligram. These reduce the volume and increase the pH of gastric secretions, aiming to get that pH above the critical 2.4 level.
And it needs some time to work, right?
They do, about 30 to 60 minutes. Then you add prokinetics, like metoclopramide 10 milligram IV. This drug increases the tone of the LES and simultaneously stimulates antral contractions, thus promoting gastric emptying.
Preparation. If RSI is a race, then preparation is the foundation of the track. It's often cited as the most crucial element. Let's structure this as the definitive pre-induction checklist for the operating room.
Meticulous preparation isn't just a phrase. It's the only way to mitigate risk in a procedure that is designed for speed.
First up, patient positioning.
You must achieve the optimal position for laryngoscopy. The sniffing position, cervical flexion, and neck extension. This aligns the oral, pharyngeal, and laryngeal axis.
And crucially, the patient has to be on a tiltable trolley.
Absolutely. Given the high risk of aspiration, the patient must be on a tiltable trolley. If massive regurgitation or active vomiting occurs before the airway is secured, the team must be able to move immediately to a rapid, steep Trendelenburg position. We're talking at least 10 to 15 degrees head down, combined with a left lateral tilt to use gravity to drain contents away from the glottis.
Next, monitoring and 4V access. We know the ASA standard, but what specific additions are mandatory for RSI?
Standard ASA monitoring ECG, NIBP, SpO2 is the minimum. But RSI requires two critical high-stakes components. First, mandatory anti-CO2 monitoring must be established and verified as working before induction starts. This is the primary non-negotiable method of confirming ETT placement.
And the second component?
You must secure two large bore IV accesses, 14 to 16 gauge, prior to induction. One line is for the RSI drugs. The second is reserved for immediate fluid resuscitation, blood products, or vasopressor support. This is especially crucial if the induction agent causes a precipitous drop in blood pressure in an unstable patient.
Equipment preparation. The definitive airway tray checklist. If you miss one item, the whole procedure is compromised.
The equipment must be checked and confirmed functioning. You need tested, cuffed ETTs. Always check the cuff inflation before use. And not just one, but a selection of appropriate sizes, plus a size smaller and larger.
And 2 laryngoscopes.
2 functioning laryngoscopes. Check the bulb light sources and batteries on both blades, often a Macintosh and a Miller. A gum elastic bougie, or introducer, must be immediately accessible for difficult views. And finally, alternative devices, a video laryngoscope or a size-appropriate LMA, must be on the difficult airway trolley and ready to go within seconds.
And the often forgotten component that is critical for managing aspiration suction readiness.
Suction is your immediate defense against aspiration. The apparatus must be switched on, connected to a wide-bore suction catheter. A Yankauer tip is preferable, and positioned within immediate, easy reach of the person doing the laryngoscopy.
A common exam trap is asking what's often forgotten, right?
Yes, and the answer is often checking the patency and the power of the suction.
Let's discuss the safety net. Pre-oxygenation. Why is achieving that perfect EDO2 target superior to just waiting 3 minutes?
The rationale is denitrogenation. We're replacing the nitrogen in the patient's functional residual capacity, or FRC, with 100% oxygen. This maximizes the oxygen reserve in the lungs, extending the safe apnea time.
And the standard technique is 3 minutes.
The standard technique is 100% O2 for 3 minutes using a tight-fitting mask with tidal volume breathing. However, the superior examiner-approved answer is pre-oxygenating until the measured end-tidal oxygen fraction, the ETO2, reaches 90%.
Why is that better?
Relying on a timed technique assumes normal pulmonary function and a perfect mask seal. Reaching 90% TO2 is an objective measure. It confirms adequate denitrogenation regardless of lung pathology or patient compliance.
That 90% ETO2 target is our firewall. But for the critically ill patient, the acidotic septic shock patient, or the morbidly obese patient, what are the pitfalls of relying solely on the standard 3-minute technique? And how does non-invasive ventilation, or NIV, help?
The standard technique often fails in these patients because they have high oxygen consumption and significantly reduced FRC. They will desaturate rapidly, sometimes in under 60 seconds.
Which is where NIV comes in.
This is where NIV pre-oxygenation becomes necessary. This involves applying 100% IO2 with pressure support and about 5 centimeters of H2O of PEEP for 3 minutes. The PEEP helps to recruit collapsed alveoli, it opens closed airways, especially in obesity, and it allows for much better gas exchange, significantly boosting the oxygen reservoir compared to just tidal volume breathing. It lengthens the safe apnea time. It's a crucial modification in the critically ill.
Okay, let's talk pharmacology. Drug selection is dictated entirely by the patient's hemodynamics and comorbidities. The art of RSI is really in choosing the right agent for the right patient. Starting with the induction agents, we have 4 main contenders. Let's begin with Propofol, the modern common standard.
Propofol is popular for RSI because of its rapid onset and clear endpoint, but its use requires very careful clinical judgment. The major risk is profound hypotension.
Why does that happen?
It's caused by a combination of significant peripheral vasodilation and mild direct myocardial depression. In a hypovolemic trauma patient or a severely septic patient, even a standard induction dose can cause a precipitous hemodynamic collapse that is very difficult to recover from quickly.
So you have to be very careful with the dose.
You must be. If you use it in unstable patients, it must be highly titrated, and doses often need to be reduced significantly, sometimes to less than 1.0 mg/kg, with simultaneous preparation of vasopressors.
Thiopentone was the gold standard for decades. While its popularity has waned, it still has its place. What defines its utility?
Thiopentone speed is undeniable. Its key benefit, which maintains its use in specific cases, is its profound effect on cerebral physiology. It rapidly reduces the cerebral metabolic rate of oxygen CMRO2 and cerebral blood flow, CBF, which is instrumental in decreasing intracranial pressure.
Making it a traditional choice for neurosurgical RSI?
Exactly. But like Propofol, it is a negative inotrope and vasodilator, though generally less severe than Propofol. A critical exam point is remembering to adjust the dose in patients with significant renal or liver dysfunction, as its clearance is heavily reliant on those systems.
Moving to the cardiostable options, Etomidate is often described as the safest choice for the sickest patients. Why is that?
Etomidate is preferred in hemodynamically unstable patients, like in severe sepsis or cardiac shock, because it is extremely cardiostable. It causes minimal changes in heart rate or blood pressure.
How does it achieve that stability?
through its minimal effect on the sympathetic nervous system. It also shares thiopentone's benefit of reducing CMRO2 and ICP. However, there is a caveat.
The adrenal suppression.
The transient adrenal suppression. This is a high-yield exam point. Etomidate inhibits the enzyme 11-beta-hydroxylase, which is crucial for cortisol synthesis.
That adrenal suppression mechanism is a critical detail. But is a single bolus dose truly clinically significant, especially in non-septic patients? Or is that risk mostly theoretical outside of a continuous infusion?
That's a great clinical question, and the current consensus is nuanced. While the biochemical suppression of cortisol is detectable, strong evidence that a single bolus dose negatively affects major patient outcomes in the general population, or even in trauma patients, is surprisingly mixed.
But in septic shock,
In patients with septic shock who are already running on maximal endogenous steroids, the inhibition may be detrimental. So for the exam, you must state the risk of adrenal suppression. But for clinical practice, you must weigh that minimal risk against the maximal benefit of hemodynamic stability in a crashing patient.
finally, ketamine. It's seen a huge resurgence in emergency and trauma, RSI. How does its mechanism make it an ideal choice for shock and sepsis?
Ketamine, a dissociative anesthetic, is a unique choice because it acts as an indirect sympathomimetic. It stimulates the release of endogenous catecholamines.
So it actually supports the cardiovascular system.
It does. It leads to an increase in systemic vascular resistance, SVR, and cardiac output. This makes it ideal for managing shock, septic patients, or those with severe asthma, as it provides induction while actively supporting blood pressure and maintaining airway patency.
What are the risks to be aware of?
Well, it increases cerebral blood flow and oxygen consumption, so it must be used cautiously in patients with known uncontrolled elevated ICP. It can also be associated with cardiac ischemia in those with severe coronary artery disease due to the increased myocardial workload.
So the criteria for drug selection boil down to optimizing hemodynamics and mitigating that reflex rise in ICP or blood pressure during intubation. The takeaway for the student is etomidate or ketamine for severe instability, thiopentone or propofol for neuroprotection if hemodynamics allow.
Precisely. And remember to address the sympathetic surge caused by laryngoscopy. To blunt that noxious stimulus, you should consider supplementing the induction with agents like fentanyl or a bolus of intravenous lidocaine, about 1 to 1.5 mg/kg IV just before intubation.
Now for the NMBAs. We have a clear choice between the traditional agent Succinylcholine and Rocuronium. Starting with SG, what keeps it the standard for classical RSI?
SG is the classic choice because its depolarizing mechanism offers the gold standard for speed, the fastest onset, 60 to 90 seconds, and the shortest duration, 7 to 12 minutes.
That short duration is key, isn't it?
It's the paramount advantage in a failed airway scenario.
Okay.
It means rapid spontaneous recovery if intubation fails. The standard RSI dose is high, 1.0 to 1.5 mg/kg IV.
But the contraindications list is extensive, and they are definitely high-yield exam questions. We need to detail the specific physiological mechanisms behind the major contraindications, especially the high-risk hyperkalemia triggers.
This list must be recited perfectly, emphasizing the risk of life-threatening hyperkalemia. First, known or suspected hyperkalemia. S naturally causes a transient rise in serum potassium in all patients, but this can be catastrophic in patients with pre-existing high potassium, like an end-stage renal disease.
Okay.
Second, malignant hyperthermia susceptibility. And third, conditions leading to the upregulation of extrajunctional acetylcholine receptors. This is the key mechanism leading to massive potassium release.
And which conditions are those?
Burns greater than 48 hours old, up to 1 year post-injury, severe acute or chronic neuromuscular diseases like muscular dystrophy, and spinal cord trauma or severe denervation injury, where it's contraindicated for up to 6 months.
Let's focus on that burn and spinal cord injury mechanism. Why the 24 or 48-hour cutoff? Why isn't S contraindicated immediately after the trauma?
That timing is crucial and a frequent exam trap. Immediately after the injury, in the first 24 to 48 hours, the upregulation of these extrajunctional acetylcholine receptors hasn't happened yet.
It takes time for the body to create them.
Exactly. It takes time for the body to sense the muscle injury and begin this proliferation. Once these new receptors are established, after 24 to 48 hours, SE interacts with them and causes a massive, uncontrolled efflux of potassium, which can lead to ventricular fibrillation and cardiac arrest. Before that window, SE is generally considered safe for RSI.
This is where Rocuronium comes in as the primary alternative. What is its role, and what specific dose is required to match SE's speed?
Rocuronium is the non-depolarizing relaxant of choice when SCs is contraindicated or when the risk of a difficult airway is high. To achieve that necessary rapid onset of 60 to 90 seconds for RSI, rocuronium must be administered at a very high dose, 1.0 to 1.2 millikilograms.
Which is about double the standard dose.
It is approximately twice the standard intubating dose of 0.6 millikilograms. This high dose achieves rapid saturation of the receptors, mimicking the onset of SC.
And the major rationale for its increasing popularity, despite its much longer duration of action. This has fundamentally changed RSI practice.
The game changer is Trigomodex. Trigomodex acts as a selective relaxant binding agent. It essentially encapsulates rocuronium molecules in the plasma, rendering them inactive.
And that pulls more rocuronium off the receptors.
Exactly. It creates a concentration gradient that rapidly pulls rocuronium off the neuromuscular junction receptors. This allows for the rapid and predictable reversal of even deep rocuronium blockade.
So the biggest drawback of a long-acting agent is gone.
It's effectively mitigated. The prolonged paralysis in a failed airway scenario is no longer the primary concern, making it a very safe alternative when S-time is undesirable.
We're moving into the core technique section now. For a high score, you have to be able to describe the classical RSI flow in a logical, step-by-step manner. Let's map out the classical 8 steps.
This sequence must be memorized flawlessly. No steps missed, perfect timing. Step 1, preparation. The checklist. Meticulous check of equipment, 2 IV lines, full monitoring, including EdCO2.
Step 2, pre-oxygenation.
100% O2 for 3 minutes, or, even better, until EtO2 is over 90%. Step 3, cricoid force, the initial awake force. The trained assistant applies a light cricoid force of 10 newtons, which is about 1 kilogram of force, just before the induction drugs go in.
While the patient is still conscious.
Yes. Step 4, rapid drug push, the induction agent, immediately followed by the NMBA. Step 5, increase the cricoid force. As soon as the patient loses consciousness, the force is increased to 30 newtons, or 3 kilograms of force to fully occlude the esophagus.
Then step 6 is the intubation itself.
Right. Laryngoscopy and tracheal intubation, aiming for success within that 60 to 90-second window. Step 7, cuff inflation and confirmation. Once the ETT is visually past the cords, the cuff is immediately inflated, and tube position is verified, primarily by confirming that EtCO2 waveform.
And the final step, step 8.
Release cricoid force. Only after the cuff is inflated and the tube position confirmed, the anesthesiologist instructs the assistant to release that 30N cricoid pressure.
The most controversial element within those 8 steps is definitely cricoid pressure. We have to address both its original rationale and the modern controversies because the examiner is testing critical thinking versus historical dogma.
Right. The rationale, established by Sellick in 1961, is that firm downward pressure on the cricoid cartilage, the only complete ring in the larynx, compresses the underlying esophagus against the cervical vertebral bodies. It's meant to create a temporary physical barrier.
But wait, if the Sellick maneuver is so controversial and the evidence base is so weak, why is it still step 3 in your classical 8-step recital? Is this a case of dogma overriding clinical evidence? And what is the real risk of maintaining its use?
It remains in the classical recital because of historical inertia and, the theoretical benefit. The thinking is, if it works even some of the time, it might be worth keeping. However, you must discuss the controversies for the exam.
Which are?
1, there's a lack of efficacy evidence. There are no modern randomized controlled trials that definitively prove that cricoid pressure reduces the incidence of aspiration pneumonitis.
And 2, the anatomical reality.
Yes. MRI studies often show that the force doesn't compress the esophagus centrally, but often results in its lateral displacement. Or sometimes it can even occlude the trachea in pediatric patients, rather than the intended esophageal occlusion.
And most critically, it can make intubation harder.
It can. Cricoid pressure is documented to worsen the laryngoscopic view in up to 30% of patients. This potentially lengthens the time required for intubation and, ironically, increases the time the airway is unprotected, thereby increasing aspiration risk.
This feeds directly into the classical rule of RSI, the strict avoidance of mask ventilation. Why is this rule so strict in classical RSI?
The classical RSI dogma is no PPV, no positive pressure ventilation. This is to prevent gastric insufflation. Introducing air into the stomach via the esophagus dramatically increases intragastric pressure.
And that pressure could force stomach contents up.
It could be strong enough to overcome the weakened LES and force gastric contents into the pharynx, rapidly leading to aspiration. Hence, the traditional technique demands moving directly from apnea to intubation with minimal delay, sacrificing ventilation time for speed and safety.
Now let's look at the modifications. Classical RSI is rigid, but modern critical care requires flexibility. When is a modified RSI indicated, and why is this often the preferred approach today?
Modified RSI is indicated in critically ill patients, especially those who are profoundly hypoxic, severely acidotic, or have a low baseline FRC, like morbidly obese or pregnant patients.
So in these patients, the risk of desaturation is higher.
Exactly. The risk of rapid catastrophic desaturation during the apnea period is judged to be higher than the perceived risk of gastric aspiration. The modern approach acknowledges that hypoxia is the most immediate life threat.
What are the two main differences between classical and modified RSI that the student needs to list?
The primary differences are the ventilation strategy and the NMBA selection. Modified RSI shifts away from mandatory cricoid pressure and favors the use of high-dose rocuronium backed by Succinylcholine for rapid reversibility. And most importantly,
It allows for mask ventilation.
it involves the cautious and gentle inclusion of mask ventilation if necessary to stave off critical hypoxia.
Tell us more about gentle mask ventilation. When and why should we risk breaking that classical rule?
You should initiate gentle mask ventilation only if the CPO2 is rapidly declining toward critically low levels, say dropping below 90% in a previously well-oxygenated patient, or if the patient is severely acidotic and cannot tolerate apnea.
And the key is gentle.
The key is gentle, meaning low pressures, usually aiming for less than 20 centimeters of H2O peak inspiratory pressure, and controlled small tidal volumes. This minimizes the chance of gastric insufflation. Studies have shown that gentle mask ventilation, when employed strategically, limits life-threatening hypoxia without increasing the overall rate of pulmonary aspiration.
So it's about balancing the risks.
It is. You're balancing the immediate risk of hypoxia, which has a high mortality, against the theoretical risk of aspiration, which has a moderate mortality.
Let's address the modified RSI approach in specific high-risk groups. Pediatric and obstetric patients.
In pediatrics, modified RSI is often the default choice. Children, especially infants, have a high metabolic rate relative to their low FRC. This means they desaturate much faster than adults, often within seconds.
So the priority is preventing bradycardia and hypoxia.
It is. Furthermore, the controversy around cricoid pressure is amplified. Due to the softness of the tracheal cartilage in small children, external cricoid pressure can easily compress the airway, leading to obstruction. So gentle, controlled ventilation is often used.
And for obstetrics?
The key modification is mandatory positioning. Pregnant patients requiring RSI must be placed in a left lateral tilt of 15 degrees to prevent aortocaval compression by the gravid uterus.
Which can cause severe hypotension.
It can. Rocuronium is frequently preferred as the relaxant, and meticulous pre-induction prophylaxis is mandatory due to that hormonally suppressed LES tone.
RSI is fundamentally an airway skill performed under duress. Let's focus on the intubation phase itself. We mentioned blunting the sympathetic response earlier. How crucial is this in managing the patient's physiology?
It is exceptionally crucial, especially in patients with existing cardiovascular or cerebrovascular disease. Laryngoscopy and intubation trigger a rapid and significant release of catecholamines.
Which leads to a surge in heart rate and blood pressure.
An acute rise, yes, and it can potentially increase intracranial pressure. This surge can be blunted effectively by administering IV lidocaine 1 to 1.5 milliliters a minute or two before induction, or by using short-acting narcotics like fentanyl, or even beta blockers like esmolol. Failure to do so risks catastrophic events like a stroke or myocardial infarction.
Given that RSI is often performed urgently on potentially difficult airways, what's the mandatory checklist for backup plans? The Plan A, B, C mantra.
You must approach this systematically. Plan A is your standard direct laryngoscopy. Plan B must be the immediate use of a different device. The video laryngoscope is essential here, as it often provides a superior view. A gum elastic bougie should be the first adjunct used when the view is suboptimal.
And what if the view is poor during direct laryngoscopy?
The intubator must immediately ask the assistant to release the cricoid pressure. That maneuver may be the sole cause of the poor visualization. If all attempts at intubation and ventilation fail, you move immediately to Plan C. The cannot intubate, cannot ventilate, or CICV scenario, which requires an immediate call for surgical airway assistance.
You mentioned the role of video laryngoscopy, or VL. Is it becoming the new standard for RSI?
I would say yes. VL has moved from a difficult airway adjunct to standard equipment on the airway trolley for all RSI cases. It provides a predictably superior view of the glottis compared to direct laryngoscopy in many patients,
Potentially reducing intubation time.
and reducing complications related to repeated attempts. Its availability is crucial, particularly in patients requiring manual inline stabilization, like those with suspected cervical spine injury, where neck manipulation is contraindicated.
And finally, the role of supraglottic airway devices, SADs, like the LMA. They are generally contraindicated with a full stomach, so how do they fit into the RSI protocol?
This is a classic exam question, testing your understanding of risk hierarchy. SADs are generally contraindicated with a full stomach because of the high risk of aspiration. However, in the scenario of a failed RSI where you cannot intubate and you cannot ventilate, the CICV scenario, the priority immediately shifts from preventing aspiration to preventing death from hypoxia.
So the LMA becomes a rescue device.
In that critical moment, the LMA becomes the essential rescue ventilation device. You use it to oxygenate the patient, accepting the aspiration risk as the lesser of two fatal evils.
Let's transition to complications. This is a major section in any exam. What is the most immediate life threat during RSI?
The most immediate life threat is undoubtedly hypoxia. This stems primarily from either inadequate pre-oxygenation, failing to get that ETO2 over 90%, or a prolonged apnea time due to a difficult intubation.
And patients with low FRC crash very quickly.
They can in under 60 seconds. Management is immediate. Check for esophageal intubation, check for equipment failure, and if you can't intubate quickly, you must initiate gentle mask ventilation or transition immediately to a rescue device like a bougie or VL, or if necessary, an LMA to restore oxygenation.
We discussed the relationship between failed intubation and cricoid pressure. Can you elaborate on the practical steps when laryngoscopy fails due to a poor view?
If the initial laryngoscopy attempt results in a poor Cormack-Lethane grade 3 or 4, the first action is to optimize the view using external laryngeal manipulation, the BURP maneuver.
And if that fails?
If that fails, the intubator must immediately ask the assistant to release the cricoid pressure. If the view improves, it confirms the cricoid pressure was distorting the anatomy, and the intubation can proceed rapidly without it. If the view remains poor, you move immediately to Plan B, the bougie or the VL.
The ultimate failure of RSI is aspiration. If active vomiting or massive regurgitation occurs before the cuff is inflated, what is the precise, immediate management protocol? This is a guaranteed Viva question.
This is a critical distinction that must be handled with precision. First, release the cricoid pressure immediately. This is the absolute first step.
Why is that so important?
Failure to do so risks esophageal or pharyngeal rupture if the patient is actively vomiting against that high pressure obstruction caused by the 30N cricoid force.
Okay, so release pressure first. Then what?
Simultaneously, the patient must be rapidly placed in a steep left lateral head-down position, a Trendelenburg tilt. Use gravity to drain gastric contents away from the glottis. Third, suction. Aggressively suction the oropharynx and hypopharynx with high-flow, wide-bore suction.
And then reattempt intubation.
Only once vomiting has ceased and the pharynx is cleared should intubation be reattempted, ideally with the patient still slightly head down, to secure the airway and inflate that cuff.
Let's cover hemodynamic instability. We often see both hypotension and hypertension. What defines the differential management?
Hypotension is usually a consequence of the induction agent Propofol or thiopentone in a patient who is hypovolemic or septic. Immediate management involves rapid volume loading via that second large-bore IV and immediate administration of a vasopressor.
And hypertension and tachycardia.
That results from insufficient anesthesia depth, so the patient is reacting to the painful stimulus of laryngoscopy. Management involves immediately deepening anesthesia, a small bolus of fentanyl or more induction agent, or blunting the response with esmolol. Both conditions require a quick, calculated response.
Awareness is another major risk. How do we mitigate the risk of the patient being paralyzed but fully aware?
Awareness during RSI is horrific and often results from the NMBA onset occurring faster than the induction agent, or the induction dose being insufficient. Mitigation strategies include ensuring the full induction dose is administered rapidly and potentially using brain function monitoring like BIS to verify depth of anesthesia, though you have to be cautious with interpretation if you've used ketamine.
And finally, esophageal intubation.
This is the failure to secure the trachea, resulting in the tube entering the esophagus. The risk is heightened by urgency, especially if visualization is compromised by blood, secretions, or cricoid pressure. It's an immediate catastrophic cause of hypoxia.
And the only way to be sure is
the mandatory use of EdCO2 monitoring. It's the non-negotiable step to confirm tracheal placement. If EdCO2 is absent, the tube must be withdrawn immediately.
Let's dedicate some time to RSI modifications for special patient populations, starting with the pregnant patient. We've established the physiological risks, so what are the necessary procedural modifications?
For the pregnant patient, particularly from the second trimester on, 3 procedural modifications are mandatory. 1. Positioning. Mandatory left lateral tilt, 15 degrees, to prevent aortocaudal compression.
2. Prophylaxis.
Meticulous anti-aspiration prophylaxis. And 3. Relaxants. While AS is acceptable, Rocuronium 1.2 mg/g is a key alternative, especially if the induction is predicted to be difficult. The goal is the absolute minimum time spent in that unprotected apneic state.
Trauma patients are presumed full stomach, making RSI mandatory. We covered the S contraindication rule, but let's review the choice of induction agent in polytrauma.
In trauma, the patient is often hypovolemic and prone to shock. Therefore, the preferred induction agent is usually the most cardiostable, ketamine.
Because it supports blood pressure.
It supports blood pressure and cardiac output through its sympathomimetic effects. Etomidate is also a strong choice. You must avoid propofol and thiopentone unless the patient is definitively hemodynamically stable, which is rare in acute polytrauma. And just to reiterate that crucial timing caveat, SE contraindicated 24 hours following the injury and up to 6 months for spinal cord injury.
Obesity is an indication for RSI due to the pulmonary function changes. How does the pathophysiology of obesity necessitate a modified RSI approach?
Morbid obesity causes a dramatic reduction in functional residual capacity, or FRC. When supine, the increased abdominal pressure pushes the diaphragm up, causing atelectasis. In these patients, the closing volume often exceeds the expiratory reserve volume.
Meaning their small airways are closed even during normal breathing.
Exactly, creating a large physiological shunt. Consequently, they desaturate extraordinarily quickly. The modifications needed are aggressive NIV pre-oxygenation to recruit volume, and often inducing the patient in a ramped or head-up position to mitigate abdominal pressure and optimize the view.
And finally, pediatric patients, where RSI is modified due to their physiology.
Due to their high metabolic rate and low FRC, pediatric patients are highly prone to rapid desaturation and subsequent bradycardia. This mandates a controlled or modified RSI. The key modification is the willingness to initiate gentle, low-pressure mask ventilation immediately upon desaturation.
Prioritizing oxygenation over the risk of gastric insufflation.
Right. Furthermore, many clinicians omit or significantly reduce cricoid pressure in very young children due to the risk of soft tracheal compression, which can worsen, not protect, the airway.
To prepare for those high-scoring comparison questions, let's explicitly delineate the differences between the techniques and the drugs. First, RSI versus modified RSI. This needs to be a clear, simple distinction.
The comparison is straightforward. In classical RSI, the primary goal is minimizing aspiration risk, while in modified RSI, it's minimizing hypoxia risk.
And the big difference is ventilation.
Mask ventilation is strictly avoided in classical RSI, but it's permitted if hypoxia is imminent in modified RSI. Cricoid pressure is mandatory dogma in classical, but often omitted or used cautiously in modified. And the relaxant preference often shifts from SG in classical to Rocuronium with Succinylcholine in modified.
Now, the definitive comparison table, Succinylcholine versus Rocuronium in RSI. The depth of this comparison shows true mastery.
Okay, so both are given at high doses for RSI SG at 1 to 1.5 millitecalogram, Roc at 1.0 to 1.2 milligicaleros. This gives both an onset time of 50 to 90 seconds.
But the duration is vastly different.
Hugely different. SE is very short, 7 to 12 minutes. Roc is intermediate, 50 to 70 minutes. The mechanism is depolarizing for S, non-depolarizing for Roc.
And the contraindications.
Extensive for S. The hyperkalemia risks, MH, burns. Very few for Roc. And the key difference, reversal. SG is spontaneous, but Rocuronium can be rapidly reversed by Succinylcholine.
For the exam, what's the most important takeaway regarding Rocuronium's rising status? Is the evidence suggesting Roc with Succinylcholine is now superior to SG for high-risk airways?
The key point is that the availability of Succinylcholine fundamentally shifts the risk-benefit equation. Rocuronium at 1.2 mg/kg offers intubating conditions only marginally inferior to SITCHA, but the ability to guarantee reversal within minutes eliminates the greatest historical fear of the non-depolarizing agents in a failed airway scenario.
So it's become the safer, more predictable choice.
When ESH is contraindicated, which includes massive trauma after the 24-hour mark, Rocuronium with Succinylcholine provides the safest, most predictable, and most reliable alternative. It's become the globally preferred agent in many high-stakes emergency departments and critical care units today.
Let's focus on the quick-fire knowledge necessary for the Viva, simulating a faculty grilling. What are the top 3 frequently asked Viva questions on RSI?
1. Enumerate the contraindications of succinylcholine and explain the mechanism behind the 24-hour rule. You must mention receptor upregulation. 2. How do you manage active vomiting during RSI? The answer is release cricoid, tilt left lateral, and suction. 3. Detail your pre-oxygenation technique and when do you know it is adequate? The answer is ETO2 over 90%.
What are the common student mistakes that examiners look for? The clinical pitfalls that show a lack of preparedness.
The most common technical mistakes are 1. Suboptimal rocuronium dosing using 0.6 instead of 1.2 mg/kg, which fails to achieve RSI speed. 2. Inadequate pre-oxygenation. 3. Failure to release cricoid pressure during vomiting, which is catastrophic. And 4. Selecting the wrong induction agent, like using Propofol in a patient in deep shock.
And what are the examiner-approved safe answers that demonstrate preparedness and critical thinking over rote memory?
The safe answers revolve around mitigating risk, stressing meticulous preparation using the checklist, highlighting that your choice of induction agent is dictated solely by the patient's hemodynamic status, so Etomidate or Ketamine for severe shock, and always emphasizing that Rocuronium at 1.2 mg plus Succinylcholine is the gold standard when SC is undesirable or contraindicated. It shows you understand the modern evidence base.
In a 20-mark long answer, presentation matters as much as content. How should the trainee approach the RSI flowchart and diagrams?
Visual aids are essential for clarity. You should draw a simple linear flowchart of the RSI steps: preparation, then pre-ox, then cricoid 10N, then drugs, cricoid 30N, intubation, cuff, and finally release. This instantly demonstrates your mastery of the logical flow.
And the Sellick maneuver diagram. How should they draw this anatomy?
Draw a simple sagittal view of the neck. You must clearly illustrate the relationship between the structures. Show the cricoid cartilage as the incompressible ring, with the force vector 10N and 30N, pushing it posteriorly to occlude the esophagus against the underlying cervical vertebral body. Label the trachea anteriorly and the esophagus posteriorly. Included the force numbers is crucial data.
Finally, how should the student structure their entire 20-mark answer on RSI to ensure maximum coverage and a high score?
Use the major sections of this deep dive as your blueprint. Start with an introduction definition, purpose, then physiology, focusing on aspiration risk, then a comprehensive list of indications. Follow that with preparation, the checklist, then drugs with the SC versus ROC comparison table, then the technique with the 8-step recital and the cricoid controversy, then complications, and finally a polished conclusion. This template ensures a complete, high-scoring essay.
That covers an enormous amount of high-yield ground. Let's finish with a rapid-fire recap of the most critical facts, the 15 take-home points that must stick with the trainee as they walk into that examination hall.
Absolutely. Memorize these points. 1. Aspiration risk thresholds are 0.8 milloncology volume and pH less than 2.4. 2. Clear fluid fasting time is less than 2 hours. 3. Pre-oxygenation goal is ETO2 over 90%.
4. Cricoid force is 10 newtons awake, 30 newtons after LOC.
5. S-dose dose is 1.0 to 1.5 milligilokilograms. 6. Rocuronium RSI dose is 1.0 to 1.2 milligilokilograms. 7. SC is contraindicated in burns over 48 hours and spinal cord injury up to 6 months. 8. Etomidate is preferred for the hemodynamically unstable. 9. Ketamine maintains or increases SVR and cardiac output in shock. 10. If the intubator's view is poor, immediately request cricoid pressure release.
11. If active vomiting occurs, immediately release cricoid pressure and tilt the patient left lateral.
12. Modified RSI is for critically ill patients to allow gentle mask ventilation. 13. Rocuronium block can be rapidly reversed by Succinylcholine. 14. Pregnancy requires mandatory left lateral tilt. And 15. The presence of its CO2 is non-negotiable for ETT confirmation before releasing cricoid pressure.
That is a phenomenal summary, giving the trainee not just the facts, but the structure required to deliver a high-scoring answer.
And finally, when concluding your long answer, deliver a final, polished summary statement that ties together the history and the future of RSI.
Give us that model conclusion paragraph.
Rapid sequence induction, based on the foundational principles established by Stept and Safar, remains the critical technique for managing the high-risk airway in emergency settings. However, modern evidence-based practice mandates a nuanced approach, recognizing the anatomical limitations of the Sellick maneuver and the necessity of preventing hypoxia in the critically ill. Driven by advancements like videolaryngoscopy and the highly reliable reversibility provided by Rocuronium and Succinylcholine, the future of RSI emphasizes achieving swift, definitive intubation and minimizing the duration of apnea, ensuring patient safety remains the paramount objective over rigid adherence to historical dogma.
That brings us to our final provocative thought. Given the strong evidence that cricoid pressure often displaces the esophagus laterally rather than truly occluding it, and that rocuronium and Sagamodex provide predictable control over the duration of paralysis. Is the future of RSI truly rapid, reliable intubation and reversal minimizing the apnea time, rather than relying on this historically rigid but scientifically controversial manual maneuver? Think about the evidence versus the inertia of decades of medical training.
It raises an important question. How much does dogma guide our actions? And how much should clinical evidence? Critical thinking, constantly weighing the immediate risk of hypoxia against the risks of aspiration, is what separates the expert physician from the novice. We wish you the very best in your preparation for your MD anesthesiology exams. Study hard and stay safe.